Hey, all, welcome to another episode of Nurse Stories. Today, I'm all alone. It's just going to be me and my guy behind the scenes, Nathan, who will be asking me some questions throughout the broadcast today. So if you hear an eerie voice in the background, that's Nathan. So we've had him on the podcast before, uh, but today he's just a voice in the background. But anyways, I want to give a big shout out to our sponsor. Who's our sponsor? Five Square Aesthetics. Five Square Aesthetics are the people helping nurses realize their dream. They have everything they need to get going in aesthetics, from education to legal work to finding a medical director. Heck, they'll even let you order supplies. So if you want to get into aesthetic and you're a registered nurse, reach out to them. They know the way, they know how best to do it, and they will get you where you want to be. So let's get going. What are we doing today, Nathan? What's on the docket?
Yeah, I thought we could talk today about AI in healthcare, kind of go over some of those things. So I think there's one really big overarching question that I personally would have, and it's if AI can diagnose, predict, or detect diseases, illnesses, or abnormalities at a higher percentage than humans can, is it morally or ethically okay to continue having humans screen for these issues?
That's a really interesting question. So let's go back to like when I was in school. When I was in school, I had a preceptor who, I was doing my rotations through the clinics, and I think I was in urgent care. And big shout out to Dr. Swainston for helping me out there. But he told me something that has stuck with me every day, which is 95% of a diagnosis is what your patient tells you. The remaining 5%, you confirm your suspicions with the physical exam. So what does that mean? So let's say a patient comes in and they're like, oh, I feel sick. And you start asking them questions. And we have a very systematic way of asking questions. When did it start? Where is the issue? How long has it been going on for? What is the character of the complaint? Are there any associated factors with it? What's the severity? What things make it better? What things make it worse? Et cetera, et cetera, et cetera. And based off those initial questions, you'll refine your answers. And so we have in our heads this logbook of a pathway to getting to the bottom of things. And then when you get stumped, you're like, I think it's X, Y, and Z. We call those differential diagnosis. So differential diagnosis means, it could be X, Y, or Z. I'm not sure, but let me throw a test at it to delineate. So perfect example, patient comes in and they're complaining of, a cough. Okay. Well, a cough could be anything. It could be you smoked before you walked in the room, or it could be you've been exposed to asbestos your whole life. So from, an environmental contaminant to, mesothelioma. And you're like, okay, it could be lung cancer. There's a litany of other stuff. So you start asking questions, right? And you're like, okay, how long's it been going on? Oh, 3 weeks. Okay, well, it's not mesothelioma if it's only been going on for 3 weeks. Okay, well, what happened? Well, 3 weeks ago I got sick, and I had a cold, and I got over that in about 5 days. But I just have this chronic cough. You're like, okay, well, there goes, cancer. There goes, all these other environmental hazards, maybe the flu, you've already checked their vital signs. They don't have a fever or chills or anything like that. So you can start to deduce what's going on. And then you get going a little bit more and they're like, yeah, I have, not on any medication. So then you eliminate all the medications that cause coughing, et cetera, et cetera, et cetera, until you get down to two or three things. And you're thinking, I suspect this is bronchitis. You had a cold, you irritated the bronchioles. So I'm suspecting bronchitis, but maybe they have walking pneumonia. Okay. I can't delineate between the two. So what do? You order a test. Okay. So 95% of the way there, the last 5% is a test. And the test would be a chest x-ray. Radiologist gets on there and goes, nope, you got bronchitis, and boom, you're good to go. Okay. Or the radiologist gets on there and goes, you got pneumonia, and then you're going to prescribe antibiotics and things like that. So Nathan's question is, can AI do the 95%? 100% yes, and probably to a greater degree of accuracy. If you go to like any emergency room in the country, the physicians there have a book about this thick where it has a flow chart. and you go through the book and you get to chest pain and it says, okay, chest pain, this is the way you go. Run these labs, do this, do this, do this, do this, do this. And then you do all that and it'll get you to the diagnosis, okay? 99% of the time. So can AI do that? Yeah, the AI is going to ask you the questions. When did it start? Do you have a fever? Do you have chills? Do you have nausea? Do you have vomiting? Let's go all those questions. We call that a review of systems, where you go through all the systems being like head, ears, eyes, nose, throat, mouth, etc., chest, heart, lungs, extremities, skin, things of that nature. Can AI do that? 100%. I mean, it's almost doing that right now. I mean, we call them Google diagnoses, right? Patients get on and say, oh my gosh, these are all my symptoms. What do I have? And Google goes, oh, you probably have this. And they're like, oh my gosh, I got this rare thing from Zambia that's only been in the United States 2 times. It must be me. I meet all of the symptoms. Well, AI could do that to much greater degree of accuracy. So if I was a young person, like teenagers, and I was thinking about getting into medicine, I would strongly suggest you get into a skill set that requires hands-on. So what do I mean by that? Some sort of specialty or some sort of practice where you have to get hands-on with people. So for instance, aesthetics, that's what I do with most of my day. There's not a computer out there yet that can inject Botox into people. They're going to have to come see somebody like me, okay? But primary care, you watch in 5-10 years, they're going to have online databases where people can get on and find their diagnosis. I in one of my businesses that I run, we do a lot of sleep studies, and there's a new sleep study out that will have AI built into the diagnosis process. So you wear the sleep study at night in the comfort of your own home. In the morning, you push a button, AI interprets all the results to 94% accuracy. So 94% of the time, you're going to be right on. Now, that's not 100%. And when you're talking about diagnosis, we want to be 100%. And so we use that 94% accuracy to guide us. And then if there's like something that's quite wrong or quite off, then we'll use human judgment to interpret. So the thinking part of medicine, unfortunately, is probably going to go, unfortunately, maybe, I don't know. I think it's going to go to AI. The doing part of medicine, surgery, things of that nature, you're always going to have a human behind there because they have to be able to think through issues. Machines are great at systematic processes, but once they find something that's new and novel, they're not really good at fixing it. And that's where surgeries. I mean, everybody's different. Everybody's anatomy is slightly different, and I don't see machines picking up that part. So that's a great question.
Yeah, that's super interesting. The funny thing is the very next question I was going to ask is if you could talk to any student interested in the health system or health sciences and give them any advice or career guidance, what would you recommend? And you kind of did that. Sounds like hands-on is really the way to go.
Yeah, people are still going to need to go to the hospital. So if you're a nurse, you're always going to have a job. People are still going to need surgery. So if you're a specialist in surgery, they're still going to need that. People are still going to need a dermatologist to cut, sun damage and precancerous lesions off of them. Machines aren't going to do that, and they'll probably always need primary care to some extent, where machines fall short. But the colds, the flus, the day-to-day illnesses, the stomach bugs, things of that nature, it's all going to be done by AI. I mean, I think about like some avenues of medicine, like hair restoration. Yeah, there's some treatments that you have to go to the clinic for, but all the medications AI can diagnose for you. Erectile function, AI, you push a button, AI goes, hey, you have sexual dysfunction? Yeah. Do you have any heart problems? No. Boom, here's some nitrates, Viagra. Here's your prescription, things of that nature. So I don't know the extent that's being used. I know it's in medicine. For that example I just gave you, but it's definitely coming down the pipeline.
Okay, next question. Telehealth. So there's a huge push towards telehealth in recent years. Do you think that the introduction of telehealth and its widespread use is a net positive, or do you not really like it? What are some of the downsides that you see in telehealth?
Yeah, good question. So, what did I say previously? 95% of healthcare diagnosing from a provider's perspective is asking the right questions, and you can do that all in telehealth. Telehealth is booming. I do it all the time in my practice. I do hair consults via telehealth. All of the nurses in 5 Square Aesthetics consult with their medical director via telehealth. And what does it do? It breaks down barriers. People from anywhere in the United States can consult with you. Okay. Uh, and you can meet a specialist in New York or a specialist in Zimbabwe if you wanted to. It really just breaks down those barriers. What's interesting is that prior to the pandemic, prior to COVID, insurances would not reimburse well for telehealth visits. And so there was a push in medicine to not do them as much. You make more money if you have that patient get out of their car or get out of their home, drive half an hour to your office, sit in the waiting room for 30 minutes, come see you for 10 minutes, and then go home and reverse the process. Well, now a patient can just get on their computer, literally on their smartphone, and just interact with their provider. I think it's fantastic for maintenance. I think it's fantastic for, like, let's say you're a diabetic and you just need to talk to your doctor. Let's say you need a prescription refill, everything's the same. Do you really need to go see the doctor? No. Where it falls short is when you need that physical exam to verify what you're thinking. So, something's going on and you can't put your finger on it and you're like, I need to put hands on you. Like, I need to push on your belly. Like, somebody comes in with abdominal pain and they can't specify exactly what's going on. It's really hard to, do your hands-on exam through virtually. You can have the patient do some things, but not everything. So it does fall short in some aspects, but I would say 70% of, like, primary care can be done via telehealth. 70% of the day-to-day grind can be done via telehealth. I use it all the time. Here's what's interesting legality-wise. Most states, if you do a telehealth visit as a provider, so let's, I'm in Idaho. Let's say I want to do a telehealth visit in Pennsylvania. They classify the location of the visit where the patient is. And if the patient's in Pennsylvania, you have to have a license in Pennsylvania to treat that patient. And so then it gets really gray, because how is Pennsylvania going to monitor that? I mean, they could have somebody with no degree in Mexico telehealthing with them. And how are they going to find that? Or even me being in Idaho, how are they going to track me down and prosecute me in another state? So they haven't figured out the way of enforcing telehealth laws. So what a lot of providers will do is they'll do consults, which is what I do. Consults are, hey, this is what I think you got going on, but I'm not giving you any diagnosis. We're just talking. You're not leaving today with a diagnosis. You're not leaving today with any medications. You're not leaving today with any treatments. You're just leaving today with a generalized, opaque opinion, because I'm not legally licensed to practice medicine in your state. Okay, so that's interesting. Then it gets a little bit trickier. Let's say that patient lives in Pennsylvania, comes to my practice in Idaho, and I see them, and then they leave and go back to Pennsylvania. Well, because I've established care here, I can now treat them in Pennsylvania because I put face to face, I put my hands on the patient and I saw them. So this happens all the time, or it used to happen all the time when I did primary care. Like, I have truck drivers, they drive across the country and they'll call and they'll go, and we'll do a telehealth visit. Doc, I'm in the middle of Tennessee. I'm sick. I'm throwing up. Can you give me some nausea medicine, maybe some antibiotics? And I go through the process. We do a little 10-minute visit. I go, yeah, I'll call in a prescription to the pharmacy. And the pharmacy knows, even though my license isn't in the state, because I've established care in the state that I have, then we're good to go. There are some restrictions to that. The federal government does not allow you to prescribe controlled substances across state lines. So I have to have a license and a controlled substance number in that state at a location in order to prescribe narcotics. So it gets really tricky with controlled substance, and probably rightfully so. Otherwise, it would be the wild, wild west. You'd have people all over the place prescribing pills for people that are just looking to get high. So I think that's a good rule with medication. But, the sniffles, the flus, I've literally prescribed prescriptions in 20 states in the United States for these reasons. They're traveling, they're stuck, they're sick, they're not feeling good. Because I've established care with you, you are an Idaho person that happened to be in another state at the time. Now, what's going to be really interesting is there's a lot of talented people out there that don't have the medical degrees in the United States. Think Mexico, think, Africa, think even in the Middle East. I mean, there's just or Europe. And there's some providers over there without a license that are far superior to our providers. Wait until they start. How are you gonna control that? 100% they're going to start going across those demarcation lines of boundaries that are going to be working. And you can have transactions, you could diagnose, and there's not anybody's going to say anything about it. So that's where it gets a little funny. But telehealth is on the rise, and now insurance companies are paying the same prices if you went into the office. And I don't see that happening. I don't see that changing anymore. We have a business where we do upper airway issues, and one of our providers almost exclusively is on telehealth because she can do all that stuff telehealth. So it's a pretty cool tool when used appropriately, used safely, but that does have limitations.
So, next question, kind of in regards to the telehealth and ease of access to healthcare, and maybe also, like you said, price challenges with people in other countries. Um, since you could also start to have AI introduced to all those factors and more of a home solution in the future with like basic checkups and patient questions, how do you think that this will affect the insurance industry? And as a whole, do you think we're going to see healthcare become more affordable to the average person?
Yeah, insurance agency, that's an interesting question. Will it become more affordable? Probably, yes. I mean, AI's once it's built, it's free, right? All you have to do is maintain it. So those little easy diagnoses I can see going for like $10 to $20, if a machine's interacting with people, because they can literally do a million people. Whether or not insurance will pay for it, that's a whole nother thing. Insurance companies' number one rule: don't pay anybody if you don't have to. And so they'll be the last ones to adopt some sort of repayment strategy for that. Uh, and the reason is there might be good AI, might be bad AI. Outside of AI world, as a provider, you go through something called credentialing. A credentialing process is you go to a payer, let's say it's Blue Cross Blue Shield, or if you're in California, Kaiser Permanente. In order for you to have them pay you, you have to go through what's called credentialing, where they will give you some paperwork, and you will fill out a form saying, "Hey, this is who I am. This is where I'm at. This is my work history. This is where I went to school. This is my degree. This is my certifications. Here's everything about me." We call that a CV. Everything about me that you can know. Oh, by the way, here's 3 references that can attest to everything, and then they have somebody in the background that literally follow up and make sure you are who you say you are and that you are credentialed before they start paying you money. It's a tedious process, and you have to do it with every single payer. So there's companies out there that all they do is help you get credentialing. Uh, and, rightfully so, because some bozo down the road could say, "Oh, my name's Dr. Bozo," and then start getting checks and billing insurance companies. Well, they don't want to pay Dr. Bozo. They want to pay the real thing. So you have to get credentialed. And so with that comes numbers and numeric. I have an identifier. It's called an NPI number. You can look that up for any of your providers. And that NPI is unique to me. And in order for that NPI to work, that's how we bill the insurances. So will AI have an NPI number? Maybe. I can potentially see it. But my hunch is it's just going to go to a cash pay system. And with volume, the price will come down. So yeah, I think it will be adopted. Whether or not insurance gets on board, boy, they'll be the last adopters if it happens.
Okay, next question. So AI relies heavily on large data sets. A lot of it is statistics, which can be kind of broad, but obviously there's your data is thrown in there as well. So how should healthcare industry address concerns about data privacy and security as AI becomes more integrated into medical
Yeah,
practices?
data privacy. So people don't know this, but when you go to the doctor's office, you are now in the system. Not your name per se, but your data. So what I mean, like a male that's this old with these diseases are now part of this data network. And the government's using that information, hospitals are using that information, everybody uses that information. It's anonymous, but it's your data. And so the ethics are, are you okay with somebody using your data for science and education and things of that nature? Not your name. I mean, we have very strict laws about protecting patients' privacy, right? This is aside from that. Um, so will AI make it better or worse? The thing about statistics is that there's a bell curve with everything. What might make you sick might not make what somebody else sick. And so what might make you sick might make somebody really, really sick. And AI can definitely misinterpret that. Say, oh, you know what? We call those zebras. When you hear hoof prints, think horses, not zebras. But occasionally you'll have a zebra. And then really rarely, occasionally you'll have a unicorn. Like that's those once out of every 50 million diagnoses, that comes along. AI might help you find the unicorns, or they might misdiagnose unicorns. So in healthcare, anytime statistics are involved, we call those false positive, false negatives. So a false positive is, hey, you have this disease, and then in reality you don't. Or a false negative is, hey, you don't have this disease, and in reality you do. So and those are misdiagnoses. And ultimately it comes down to, if you're a computer, statistical analysis. And where does that statistical analysis come? And behind every statistical analysis is either another computer or a person. And statistics are largely misreported, largely misused, very hard science to understand. Interesting fact. Of all the mathematical sciences, statistics came last. We had algebra, we had calculus, we had all of that before statistics. Human brains just don't work well with statistics. And so statistics came very late in life. I always found that fascinating, that as often as we use statistics, it really was very late in our existence, like I think around the 1800s, where we really started utilizing them religiously. So, but if AI gets a hold of them, yeah, they're going to misinterpret them, just like a human being would.
So, if AI can predict patient outcomes or treatment efficacy with high accuracy, do you think that there will be some ethical dilemmas around patients' right to refuse AI recommended treatments? And how do you think we can navigate informed consent in such cases?
Yeah, I think patients will always have the right to refuse. I don't ever see that changing. I say that, but we just got to a situation with the pandemic where patients were kind of forced to comply, right? Mandatory vaccines and stuff like that. So I guess, could the government mandate that you comply with AI? Yeah, I suppose. I mean, they can make you do whatever they want. Do I think it's going to become a problem? No, I don't. I think people are always going to be able to opt out. And you're going to have those old timers that are like, I'm not talking to a machine. I want the doctor down the road. So there's always going to be, doctors down the road to help you out. So do I think that forced compliance is going to be an issue? No, I really don't. So those are my opinions about AI. The thing that worries me most about AI in healthcare little bit is not so much the AI, is the people behind the AI. People do some pretty nefarious things. And if you're in control of a system that is diagnosing your populace, and you can make a little tweak, and for monetary reasons or for your benefit, they're going to do it to the detriment of other people. And so that's what I worry most about. But we already have that in healthcare as well. I mean, we have bad doctors and bad providers that do things that they don't necessarily need to do for a little extra money. But AI can be programmed however you want to program it. So it's coming. I wouldn't be fearful of it. I would be cautious of it. Definitely, look forward to seeing what's out there. I mean, AI's changed my life. I use it all the time, on a daily basis. It really helps me with business. It helps me get through my day. Even Facebook's Meta AI is fantastic, the stuff that it can do. And I just saw from the Olympics a couple nights ago that Google's launching a new AI too, which would be pretty interesting. So we'll see what happens. But it's going to come. So you just got to be ready for it. So, well, anyways, that was the podcast for today, all about AI. I hope you learned a little bit of things, or at least that's my opinion on it. Keep following us, and before you know it, we'll talk again.